Okay, let's just dive right into this rigorous textbook-level explainer of the cranial venous system. Today, we're mapping out literally every critical anatomical detail of the cavernous sinus and the posterior fossa. And hey, my goal here is super simple. I want to clear up your concepts completely. I want to build such a rock-solid mental blueprint for you today that you absolutely will not need to go back and reread the textbook. We are not skipping a single important point, so let's get focused.
All right, here's the agenda for today's explainer. We've got 5 structural pillars to hit. First, redefining the cavernous sinus. Second, inflow and outflow pathways. Third, nerves of the lateral wall. Fourth, deep inside the sinus. And finally, posterior fossa venous anatomy.
Let's kick things off with Section 1, redefining the cavernous sinus.
Okay, so this is fascinating because we actually need to dispel a massive medical myth right out of the gate. For years, the classical teaching was that the cavernous sinus was this huge, singular venous space, like a giant lake with multiple trabeculations just passing through it. But the modern reality, it's completely different. Thanks to detailed injection studies and actual surgical experience, we know the sinus is really a highly variable plexus of individual veins. It's not one big cavern at all. And the crazy thing is, this venous network varies wildly from person to person. Actually, scratch that. It even varies from side to side in the exact same patient.
Now you might be thinking, well, if it's not a cavern, why on earth do we call it the cavernous sinus? It literally just got its name because it has a superficial visual resemblance to the corpora cavernosa found elsewhere in the body. But functionally, structurally, you got to think of it as a complex, totally individualized venous network.
Moving on to Section 2, inflow and outflow pathways.
Think of this like the ultimate plumbing system. The inflow into this plexus is driven by 4 main pathways. From the front, blood pours in via the superior and inferior ophthalmic veins. It also gets drainage from the brain surface through the superficial middle cerebral veins. On top of that, the sphenoparietal sinus and both the superior and inferior petrosal sinuses funnel blood straight into this central skull base hub. It's a lot of traffic.
Now, the outflow tract is where things get really complex. Blood leaves through the sphenoparietal and superior petrosal sinuses. You also have the basilar plexus acting as a major drainage route, emptying right down into the inferior petrosal sinus. Plus, some outflow dropping into the pterygoid plexus. Oh, and here is a massive detail to remember. The left and right cavernous sinuses communicate directly with each other through the circular sinus. They talk to each other anteriorly and posteriorly. This cross-communication is exactly why an infection or a thrombosis on one side can spread like wildfire to the other.
All right, Section 3, nerves of the lateral wall.
Let's orient ourselves to the lateral wall of the cavernous sinus. It is definitely not just a simple boundary. It's actually a dual-layered structure. You've got the thicker, tougher outer layer, which is the dura propria, and tucked right inside that is the inner membranous layer. And it's exactly within these layers that specific, absolutely vital cranial nerves reside, all stacked up vertically.
So what's in there? Going sequentially from top to bottom, we find the oculomotor nerve. That's cranial nerve 3. Right below it is the trochlear nerve, cranial nerve 4. Keep going down and you hit the ophthalmic division of the trigeminal nerve, or V1. And finally, sitting at the bottom, is the maxillary division of the trigeminal nerve, V2. Now pay close attention here because this is a classic high-yield fact. V2 is the only nerve in the cavernous sinus that does not exit the skull through the superior orbital fissure. Instead, it dives down and exits through the foramen rotundum. You absolutely have to commit that one to memory.
Let's keep digging. Section 4, deep inside the sinus.
If we peel our focus away from that lateral wall and look deep into the central venous plexus itself, we find some massive structures floating right in the middle. The big one, of course, is the internal carotid artery, or ICA, along with some very delicate structures intimately tied to it.
When surgeons are evaluating tumor invasion in this space, they use 3 critical classification lines running along the intracavernous and supracavernous ICA. First up is the MLL, or medial line, which runs perfectly tangent to the medial borders of the ICA. Then you have the MNL, the median line, dropping dead center through the middle of the ICA. And third is the LL, or lateral line, which is tangent to the lateral edges. Knowing these lines is an absolute game changer for surgeons to precisely communicate exactly how far a tumor has pushed in.
As the internal carotid artery snakes its way through the sinus, we divide it into 3 distinct segments. First, you have the posterior ascending segment, which happens immediately as the ICA enters the sinus.
Then it takes a sharp turn forward into the horizontal segment, and fun fact, this is actually the longest segment of the intracavernous ICA. Finally, it makes one more turn upward to form the anterior ascending segment right before it exits the roof of the sinus.
Now, floating right next to the ICA in that pool of venous blood is the abducens nerve, cranial nerve V6. And this nerve is completely unique. Why? Because unlike cranial nerves 3, 4, 15, and V2, the abducens nerve isn't anchored to the lateral dural wall at all. It sits totally free, completely inside the cavernous sinus, right up against the carotid artery. This unfortunately makes it incredibly vulnerable during aneurysms or any direct surgical approaches.
So, with all this delicate wiring, how on earth do surgeons safely get in there? They rely on incredibly precise anatomical windows. The most famous is the triangular space of Parkinson. This is a must-know surgical landmark. Its superior border is mapped out by cranial nerves 3rd and 4th. Its lower margin is framed by V1 and V6. Memorizing this exact geometry gives surgeons a safe, reliable corridor to enter the sinus without clipping any of the vital wires.
All right, moving into the home stretch. Section 5, posterior fossa venous anatomy.
Now we're zooming out to the posterior fossa. When mapping out this area using a vertebrobasilar venogram, it honestly looks like a chaotic tree of vessels. It's incredibly dense. But don't let it overwhelm you. We can break this web down into logical, structural groups.
Let's systematically catalog the anterior and superior groups first. Right at the top sits the great cerebral vein, commonly known as the vein of Galen. As we move down, we find the precentral cerebellar vein. Then, wrapping snugly around the brainstem near the tuberculum sellae, we hit a really complex web, the posterior, lateral, and anterior pontomesencephalic veins. Just below those are the transverse pontine vein, the bracho vein, and the anterior medullary vein. You have to know this anterior cluster backwards and forwards when approaching the clivus or the brainstem.
To complete our map, let's look at the posterior and inferior veins. We've got the petrosal vein and the very delicate vein of the lateral recess of the fourth ventricle. Draining the cerebellum itself are the superior and inferior vermian veins, and they're flanked by the superior and inferior hemispheric veins. And all of this intricate, delicate drainage, it ultimately funnels into the heavy hitters, the transverse, straight, and superior petrosal sinuses. Those confidently converge at the back of the skull at the torcular hierophyllae, right alongside the internal occipital vein.
So we've walked through the strict textbook architecture of the cavernous sinus and the posterior fossa. But I want to leave you with a real thought provoker. We know that this anatomy, especially the cavernous sinus, isn't really static. It's a highly variable, totally unpredictable plexus from patient to patient. So how does memorizing this static blueprint actually help a surgeon navigate that unpredictable reality? Well, it's all about the constants. The nerves, the ICA segments, those strict surgical corridors like Parkinson's triangle, those are your anchors. You master the constants and you can safely navigate the variables. Keep studying these structures, keep exploring, and I will catch you in the next explainer.